Long case aortic stenosis. Mr. B. Ahmed, 65 years old, farmer, non diabetic, normotensive, smoker, hailing from Jamalganj, Sunamganj, was admitted into this hospital on 10th August 2022 at 11 am through outpatient department with the complaints of increased shortness of breath for 1 month and chest pain for 6 months. According to the patient's statement, he was reasonably well 6 months back. Then he noticed shortness of breath during heavy exertion like working in paddy fields, carrying heavy goods, washing clothes, doing household works hurriedly, and it was relieved by taking rest for a while. This shortness of breath is progressively increasing in nature. Now his shortness of breath has got worse for last 1 month, which occurs during mild exertion such as doing daily activities like walking at home, bathing and dressing. Now it needs prolonged rest for improving his shortness of breath. He has repeated history of sudden awakening at midnight due to breathlessness for last 1 month and needs to go to the window for open air, and it improves after 10 to 15 minutes. He has no history of difficulty in breathing during lying flat. His shortness of breath is not associated with cold, dust, fumes, taking drugs or food, or any exposure to allergens, fever, cough, coughing out of blood, bluish or yellowish discoloration of skin and eye. It is not associated with swelling of leg, abdomen, or face, decreased urine output, and there is no diurnal or seasonal variation. He has also complained of chest pain for 6 months, which is centrally located, dull, constricting in nature, radiates to neck and occasionally to left arm. Initially occurred with moderate to severe exertion and relieved by taking rest for about 4 to 5 minutes. But for last 1 month, the severity of chest pain has increased and occurred with mild exertion and needs prolonged rest to be improved. This chest pain is not related with respiration, any posture change, or taking food. He has no history of traumatic injury to chest. He has also mentioned that he has history of transient loss of consciousness for 3 times within the last 3 months, which was occurred during working in paddy field in the time of carrying heavy goods. The period of unconsciousness was very short, about 1 to 2 minutes, and thereafter spontaneously regained his consciousness. It was not associated with any palpitation, sweating, vomiting, loose motion, convulsion, tongue bite, or involuntary micturition or defecation. It was not occurred in rest or during lying to sitting or sitting to standing position. He has also history of occasional cough with frothy sputum production with increased shortness of breath for last 1 month, which was improved with taking rest and some drugs. He gives no history of recent onset or prolonged unexplained fever, skin rash, joint swelling, joint pain, weight loss, parectal bleeding, nasal bleeding, any focal weakness of his body, speech, or swallowing difficulty. He has no history of significant sore throat, fever with joint pain or swelling during his childhood, which is suggestive for rheumatic fever. He also has no history of known ischemic or hypertensive heart disease or any known congenital heart disease, diabetes mellitus, asthma, COPD, childhood recurrent respiratory tract infection, tuberculosis, or contact with known TB patient, and documented COVID 19 infection. His bowel and bladder habit is normal. With these complaints, he had consulted with several physicians, and after evaluation, they have said that he has some sort of valvular heart disease, but he could not mention the name of his disease. He is taking some drugs for last 3 months irregularly, but could not mention the name of the drugs. He had never admitted in any hospital for his illness, and he had never undergone any invasive procedures. With these complaints, he has admitted into our hospital for better management. He was immunized as per the then government vaccination schedule and has got all doses of COVID-19 vaccination also. He is a smoker, smokes 40 pack a year, non-alcoholic, non-betel nut chewer. He is married, has 3 children. He has 2 brothers and 1 sister. His parents are not alive. His parents had died in their old age. All of his family members are in good health, and none of them has any similar type of illness. There is no family history of sudden cardiac death. He has come from low socio-economic condition. He is a farmer and one of the earning members of his family. On general examination, patient is looking ill, body build average, cooperative, decubitus anchois, pulse is 80 beat per minute, regular, small in volume, slow rising and late peaking in nature, no radioradial or radiofemoral delay. Condition of the vessel wall is normal. All peripheral pulses are present and symmetrically palpable. Blood pressure is 100/80 mm mercury in both arms. There is no postural drop. JBP is not raised. Respiratory rate is 18 breaths per minute and normal in character. Temperature is normal and periphery is warm. Patient is non-anemic, non-icteric, non-cyanosed, non-dehydrated. Leg edema and sacral edema is absent. There is no clubbing, leukonychia or koilonychia. There is no thyromegaly or lymphadenopathy. Hair and skin condition is normal. There is an IV cannula in situ in left forearm. Now, on precordial examination, apical impulse is visible and seems to be located medial to the left midclavicular line. There is no chest wall deformity. Size and shape of the chest is normal, and there is no visible scar mark. There is no visible epigastric, supraesternal or supraclavicular pulsation. Apex beat is located in left fifth intercostal space medial to the left midclavicular line, 9 cm from midline, normal in size, forceful and sustained in nature. There is presence of systolic thrill over the aortic area or right-sided intercostal space and right-sided carotid arteries. There is presence of apicocarotid delay. Left parasternal heave and palpable P2 is absent. First heart sound is normal. Aortic component of second heart sound is soft. Reverse splitting of second heart sound is present. There is a high-pitched, harsh ejection systolic murmur, crescendo decrescendo type, grade 4/6 in intensity, audible all over the precordium, loudest in the aortic area, best heard with the patient in sitting and leaning forward, position with breath hold after expiration, with diaphragm of the stethoscope which radiates to the both sides of the neck or carotids. There is also an audible fourth heart sound at the apex. During the dynamic auscultation with Valsalva, the intensity of murmur decreases. With hand gripping, the intensity of murmur also decreases. With leg raising and lying from sitting or standing, the intensity of murmur increases. With standing from squatting, the intensity of murmur decreases. With squatting from standing, the intensity of murmur increases. There is no other added sound. Lung vases are clear. Other systemic examination reveals normal. This is all about the history and examination findings of my patient. So, my provisional diagnosis is severe aortic stenosis due to degenerative cause with sinus rhythm with NYHA class 3. Thank you.